are we good to get started or more people joining?
Perfect. Yeah, and I think we're good for now, Celia. Go ahead.
All right. Well, thank you all for joining today. I'm Celia Lar, and I'm a researcher at Women's College Hospital in Toronto. And with Child Bright, I'm the co-lead of the Training and Capacity Building Group, which focuses on the training opportunities that webinars, workshops, traineeships put on, where we're hoping to be able to provide some opportunity to be able to ask some questions and learn from people that have been working in this space. So before we get started with the panel today, I would like to acknowledge the traditional territory of the Indigenous peoples who first inhabited this land and recognize that we may have people who are joining from coast to coast. So if you feel comfortable doing so, you can add your own land acknowledgement into the chat. And for myself, I'm a settler who lives, works, and plays on the Haldimand Track, which is land that was promised to the Haudenosaunee of the Six Nations of the Grand River, and are within the territory of the neutral Anishinaabe and Haudenosaunee peoples. I'm working at becoming more comfortable with giving a land acknowledgement, but I also recognize that I still have a really long way to go before I can give these acknowledgements the true value that they deserve. And I appreciate the opportunities that Child Bright has offered through training sessions that have included that time for reflection and discussion with others that are also on that learning pathway. So I'm looking forward to be able to and working towards integrating those lessons into the way that I work with Child Bright and within the other areas that I work. So we hope that the session today will continue that emphasis on learning together, and we welcome to ask your questions of the panel. I have a few that will start getting each person to introduce themselves and their connection with Child Bright, so a couple of preset ones. But if you have a question that fits well with that conversation, you're welcome to raise your hand or put that in the chat, and we can bring you in on that specific conversation. And we'll also have lots of time near the end to be able to open it up for any questions from the audience. But before we get into those panel questions, we wanted to get a little bit better understanding of who's in the audience right now, so that the panelists can make sure that they are targeting their answers towards the people that are in the room right now, so they can get the most out of this session. So Pierre, if you can launch the first poll, which is to be able to identify where you sit within Child Bright, and if you find that you don't fit in any of these categories, feel free to put your answer in the chat, and we will give that a moment for you to answer, and hopefully the results will pop up in a minute.
All right, so I think we've heard from everyone, so I will display our results.
So we have a small representation of patient and family members, mostly researchers, academics, or clinical scientists, and staff and administrators, and a couple of trainees. So it doesn't look like we have any of our implementation science experts on the call, but we've got a few. So the panelists can kind of keep these in mind within this discussion, but also that others might be watching afterwards for the recording as well. And we've got one more poll just to get a better understanding of where your kind of thoughts on the implementation science protocol, which is what we'll be talking about today. And again, if you're not sure on any of this, there's an answer for that, or you can put your response in the chat.
All right, so I think that is everyone.
Okay, so we've got a mix. More people aware of the protocol, but not involved in filling it in. Several that aren't sure what the implementation protocol is, so maybe we can kind of start to find some of the answers around that, and a few that were involved in development and filling that in. And we've got a couple, so if you want to put your answers in the chat that fit with this description, that helps us get a better understanding of where people are coming from. But again, feel free to jump in if there's anything you want clarification on, either in the chat or by raising your hand. We can hopefully make this session the most useful that we can for the work that's underway at the moment. Okay, so unless there's any questions, I will start with the first question for the panelists, which is for all of them to be able to answer so that we can get a little introduction. So we'll put this slide on for now while people do their introductions, and then we'll take it down so that we can see people's faces as we join this discussion. And, so to start off, if you can introduce yourself, your connection to ChildBright, and your connection to the implementation science protocol template, whether you've been involved with it or not. So maybe I'll start with Carrie for this first one.
Sure. So my name is Carrie Costello. I am a parent. ChildBright, I have been involved in Bright coaching for now 7 years, I believe. But also I came on in 2019 as the ChildBright patient liaison. So I was calling parents, talking to them about how their projects were going, what could be improved, either at the network level or on the project level. I also now work at the Children's Hospital Research Institute of Manitoba in patient engagement. So I have expanded my work in research slowly over time. And I have 3 wonderful children, ages 14, 11, and 8 now, just had a birthday. and they, my middle daughter is what brought me into ChildBright. She has a profound intellectual disability and a seizure disorder with Todd's paresis. So that's the perspective I'll be coming from in here, and I'll pass it off to Stephanie.
Thank you. My name is Stephanie Clegg, and I'm an implementation scientist and an assistant professor in the Department of Occupational Science and Occupational Therapy at UBC. I'm an investigator at the BC Children's Hospital Research Institute, and I'm one of the co-leads for the Knowledge Mobilization Program within ChildBright, and a co-investigator on the Jouet project. And I also have 2 kids, one of which has a neurodevelopmental condition, and so and I'm an occupational therapist by background, so I bring those kinds of lenses. I will pass off to Janet.
Good morning or afternoon, depending on where you are geographically located. My name is Janet Curran, and I'm a professor in the School of Nursing at Dalhousie University and an implementation science researcher. I am the co-lead of implementation science program with the ChildBright Network and a research chair in quality improvement and patient safety in Nova Scotia. And I'll pass it off to Alan.
Hello, I'm Alan Cooper. I am the research program manager for ChildBright, working with Stephen Miller during phase 1, and now working with Janet and Stephen in phase 2. And my relationship to this, to the document that was pre-circulated, is that I worked with others in terms of developing the protocol template to help guide the development of these projects.
Great, thanks everyone. So Pierre, if you can take the slide down, and we can attempt to spotlight the panelists. And I do have a first question, but considering that there's a few people on the call that aren't familiar with the protocol, it would be great maybe if Alan, if you can just provide a really brief background around why the protocol was developed, what it's being used for, and then we'll get into our regularly scheduled questions.
For sure. So in phase 2, well, in phase 1, there were 4 programs that make it up ChildBright. In phase 2, there are actually 5 programs with the recent addition of the EDIDI program. And what we wanted to do was to ensure that all 5 programs have representation in what is going into each project. So representatives from each of the 5 programs contributed components to the template that we're referring to here. Although I'd say in terms of page count, it is mostly focused on implementation science text boxes and questions. You'll see that all the other programs are represented there as well. And what we really wanted to do was, create sort of a constructive tool, constructive template that would help guide teams. And most, I think, ChildBright members are new to this field. help guide the team members in developing an IS project. And so it's based on the STARI guidelines, and so in addition to some of the field boxes in the template having some explanations, we also link out to some resources across the template, including the STARI guidelines.
Great. Yeah, so a lot of the projects are working through that template right now, and that's part of what we're hoping is if people have questions around that, how that gets developed, and we'll provide a little support around there. So, so a big piece of this and working on implementation projects is having a clear implementation science research question. So if you could, the first question around your experience in developing these types of questions, and what do you think is useful for the project teams to know? And I might start with Janet for this question.
Thanks, Celia. I think probably one of the biggest challenges in trying to differentiate between an implementation science question and any other type of question is the focus on the intervention itself and how that is different, and how focusing on that is different in an implementation science, with an implementation science lens. And within the Child Right Network, there's such wide variability in terms of the focus of the study and the stage that the various teams are at in terms of developing the intervention and testing an intervention, and the types of interventions that they are working with, whether that be an electronic tool or whether that be a coaching program. So there's such wide variation that it's really difficult to provide clear, like one broad scope around what is an implementation science question. But if I were to provide any guidance at all, it is, if you think about, first of all, in one category, what are those factors that might enhance the uptake of your intervention? That would be an implementation science type of question. So if we think about measuring the barriers or enablers, or if you're doing a literature review to help understand how others have implemented those types of questions, like that would be an implementation science type of question. So that's in terms of designing the implementation of your intervention. And then there are implementation science questions that are related to evaluating the implementation. So those would be questions that would be focused on, once you're at the implementation stage and you're implementing your intervention, what are the factors that influence or help you answer the question of why your intervention was or was not successful? Those are implementation science type questions. I'll stop there and hand it over to my brilliant colleagues who also can add to that.
Does anyone else have an add-on to Janet's comments?
I mean, I don't think I can say anything better than what you just expressed, Janet. That was really good. But maybe there are questions around what might constitute an appropriate question, and those are things that we can answer along the way.
Yeah, so if anyone is struggling in putting together that research question, then there are some resources that can help with that. Or if anybody has any questions about developing research questions that we can address right now, then we're very open to that as well. Okay. So again, if you have a question later, we can come back to that, but I'll move on to the next question, which is around the knowledge mobilization piece. So a question for Stephanie and her team. So if you can talk us through an example of how you would answer the KM specific questions that are in the template, and just talk us through what that might look like.
Sure. So I wanted to just start by orienting you to the section of the template. Whether you have it in front of you or not, doesn't matter, but there are two boxes that come first. The first box is to document your plan for what we call integrated KT, or IKT for short, and it's looking at involving or engaging the people who will benefit from or be impacted by the work at all stages of the process. So you don't have to wait until end of grant to engage in knowledge mobilization. What we want you to think about is who is important to connect with at each stage in the research. And then after that box, there is a table to help you think through the different aspects of developing a knowledge mobilization plan. Somebody said, can we please see a copy of the template? Is someone able to share that, or do you want me to share that?
Alan, did you have the couple of slides that go with that?
Yeah, I can share the document.
Okay, perfect.
So while he's doing that, I'll talk about the first section, the IKT. So you want to think about if there are key messages that might be important to share with different knowledge users or audiences as you go along. And so, for example, if you were working with multiple sites, you might want to share the learning and adaptations to the implementation plan that are happening at one site with the other sites, because that could help inform the work that's happening there. You might also have an advisory committee that is working with your project, and you might want to think about when you should be going back to them to share findings, to get input and move things along. And there might be external parties that might be interested in learning about what's happening during the project instead of waiting to the end when it, 4 years later. So here's the table, as you can see, and what you would be looking at here is firstly to think about what kind of knowledge users might you want to be reaching. And then, so we've given some examples under the table. You don't have to scroll down to those, but it will vary widely depending on the nature of your project. So it might be healthcare providers, it might be policymakers or healthcare leaders, it might be families, it might be youth, community partners, whomever. And you can have multiple rows in this table if it makes sense for your project. Then you think about the anticipated key messages for action. Now, these don't need to be detailed at this point. They don't need to be accurate because you haven't done the work yet, but it's just trying to start to think about what might be coming from your work that would be shareable and actionable, so that those groups could actually do something about it. And then you think about your primary goals for knowledge mobilization. So you may just be wanting to increase awareness, so focusing on dissemination. You might be wanting to improve knowledge or skills or influence attitudes with this knowledge mobilization. Maybe you're hoping for practice change or other goals. And so you would just check the box or add a comment in other to indicate what you hope to achieve with the KM around this key message for action with this knowledge user group. Next two columns are for popping in identified or expected barriers and enablers of change and the strategies that you're using. So when you're working on this, you can look to the literature to identify known barriers or enablers, facilitators of change, whatever the goal is, so changing knowledge or changing practice, and then pop those in. Or if you've done some pilot work or some in your phase 1 work and you've already identified what some of those barriers are, you can pop them in there. And then, or if you don't know, you can propose what you think that they might be. And we know that this might change over time, but it's to get you to start thinking about what would be keeping you from achieving this goal. Then the next column is for looking at the strategies that you would use to target those barriers and enablers. So when we look at implementation, it's great to frame your work in implementation theory, knowledge translation theory, and you can learn more about that through the IS experts that are consulting with your team, or by reaching out to our program or the implementation science program. But best practices in KT or KM talk about tailoring your strategies to the barriers and enablers. So for example, if the barrier was attitudes of healthcare providers, that they didn't think that this intervention was going to be good, you can do all of the skills training you want, but the barrier is about changing their attitudes. And so you would want your strategy to align with that barrier. You can use theory to help guide this practice, and again, access supports to help identify these things. And one other thing to keep in mind when you're looking at proposed strategies is the evidence behind them. So you can go to the literature to see what the evidence of the effectiveness of your strategy might be for that particular knowledge user group for the particular goal. One example is that we know that passive dissemination of written materials isn't necessarily effective at changing behavior. So if your primary goal is practice change, then just sharing resources on social media might not be the best approach. And so you might want to tailor your goal and your strategy to be in alignment with the evidence. The last column is just to check off where in the research process this KM activity would be happening. So we just grouped into, project development, data gathering, analysis, end of project, or other. You can check off one or more as it applies. And this will help you look through your plan and see, well, is everything I'm doing end of grant? Is there something that would be more appropriate to look at earlier in the process? Am I only targeting this one knowledge user group, but there's another key one that might be important? So it's really a template to just prompt you to consider all of these different aspects when you're thinking about knowledge mobilization. In terms of supports, I just wanted to mention that if you are having, if you would like support around developing a KM plan or getting feedback on something that you're drafting, you can reach out to the KM program to get support. And we can also put you in touch with our hubs. So we have a policy hub that's been established in phase 1, and they if you have something that's policy aligned, they can help talk about the ideas you have for KM around policy and give feedback to help strengthen your plan. We're also in the process of establishing a clinician hub, so hopefully of interprofessional healthcare providers. So you could throw your ideas past them and get feedback. And then also a family hub so that you could get input from that group around what they think would be the best approach, or if there are ways that you can tweak your plan. And this isn't just for the protocol development stage, but throughout the life of your project. If you would like some input in that way, you can reach out to us to access those supports. There's one more thing, is there's a tool that the phase 1 KT committee developed on IKT. It's much more detailed than what's in this protocol, but it has some guiding questions that can also help you develop that plan. So I believe it's going to be on the KT library, which is available on the ChildBright website. If you have trouble finding it, you can also reach out to me, and I will put my email address in the chat. I will stop talking now.
All right, that was great, Stephanie. Thank you. Very a detailed look at that piece. And the part I wanted to really highlight was recognizing that involving these people through a variety of people throughout the whole project is really a key part of sustaining the changes that you're trying to make, to be able to make sure that the people that can actually continue that work and take that forward are involved right from the beginning, so it fits with their need and really solidifies the changes that you're working towards or hoping to be able to do. There's also a tool that has just come out around helping to identify some barriers and enablers based on behavior change theories as well. So to be able to walk through, what your barrier could be. And it has some of that evidence in a clear, basically a chart that just pops up. So I can put that in the chat as well. We'll say if it looks really overwhelming and doesn't make sense at first, it might be something to be able to come back to a little bit later when you've got your head around some of these concepts a little bit, but able to bring in a lot of that, the existing literature in there as well.
Nice resource that summarizes the evidence on KM strategies towards healthcare providers. So I can put a link to that in the chat as well.
That'd be great. So did any of the other panelists have anything to add on the KM aspects of the protocol? Then I might just jump back to Janet, because I saw there was a few things in the chat around looking at effectiveness of research questions. So before we move on to the next piece, just wanted to see if there was anything to add on that, or to explain what you were meaning.
No, I was just addressing the question that someone had put in the chat box regarding their question or their proposed question, and whether or not that would be considered an IS question. And I do believe it was looking at estimates of effectiveness, which really is around effectiveness and not implementation science. So I'd suggest perhaps looking at, alongside that, looking at questions that may be more tailored towards looking at either the implementation strategy or the context in which it was implemented, gathering process type of data to help inform our understanding about of the effectiveness of the intervention, which in this case I think was a coaching intervention.
Yeah, so really the connections with effectiveness and implementation questions, they can be complementary, but they are different.
Yeah, I also wanted to remind folks that this panel discussion is really just a primer, that you are setting up a workshop that will give them more in-depth and detailed education related to implementation science. So
yeah, we have 2 hour-and-a-half sessions, which you've hopefully seen some advertisements for, that we have being run by the Center for Implementation. So they'll provide a bit more of that background to implementation science, thinking through barriers and facilitators. That tool that I mentioned will be brought in there as well. So this is the kind of Child Bright protocol specific sections. And then the next few sessions that are happening in November, we'll be able to dive a little deeper into some of those implementation aspects. So great from Miranda. All right, so lots of resources going in the chat, which is great. So I will then move on to the next question, which is acknowledging that citizen engagement is a huge part of Child Bright and the patient-oriented research that's done. So what are some of the different ways that you see citizens involving in this protocol, whether that's in the development, the enactment, those different phases? And I'll pass to Carrie to start us off.
Thank you. Yeah, so there's a lot of different ways that patients can be involved, and many of you have been working with patients for a while. However, I know some of you are now having to change because the implementation science project is not exactly what your phase 1 project was about, which might mean you're in the hunt of or in need of new patient partners. So just a few things to, like, if you're in that situation and you're not sure what to do, to reach out to Corinne, Citizen Engagement Coordinator, because we do have a group of parents, a group of youth that can sort of help you in the interim while we're trying to find those patients that are directly relevant to your project. So really making sure that we get that patient engagement, even if you don't necessarily have those patients right now, right here. So just putting that out there. If you do have patients, or you're moving some of your patients from phase 1 to phase 2, if you haven't gone to them and just ask some simple questions, and I'll give you some examples to get you started based on those STARI guidelines. So there's sort of the intervention questions, and then there's also the implementation science questions. So there's sort of those 2 parts. And so if they've been involved in phase 1, they know about the intervention already, and just going back to them to making sure, like, what do we measure? Because sometimes we didn't have patients involved at the very beginning of this, or things have changed over the course of 5, 6, 7 years. So going back to them, and are we measuring the right things? Are the quality of life? Are the questionnaires we're using? Is it range of motion? Is it resilience? Like, are we asking the right questions for our intervention? So just checking in on some of those things, really important at this point in the process. In terms of the intervention, asking them, just because you can go to them with your sort of protocol, but then you're sort of guiding them in a specific way. And sometimes it's really good to just ask simple questions to get them started and thinking, and you never know what you're going to get back. So what do you like, just asking them, what do you want the next steps to be? So, you know, is the end goal to be that it's available for everyone, every family in Canada for free? Is that the end goal? Is that what patients think the end goal is, or not? You know, sort of what's their end goal? How do you want to receive the intervention? So very specifically, and from who, I think is a really important question to ask your patients, because I know a lot of you are working on sort of projects that might be a practice change or something to do with clinicians, but remembering that at the end of the day, the patients are the ones who have to, you know, either implement the therapy at home or accept the therapy from their therapist. So really thinking about, is it the therapist the best way to get it? Is it best for them to have a document from the therapist to explain this new change? And that document should be looked at by patients. So sort of really thinking about, remembering that end goal is always families. How does that implementation science idea, which we're trying to get clinicians to do, which we're then trying to get patients to actually accept? So really making sure we make that direct connection. So how do you want to receive the intervention, from who? And if it's a continuation from phase 1, really asking them, what adaptations, what have we learned in the last 5 years that might actually make it work in your province? Because I know there's things that worked really well in my province that didn't work in other provinces, just because the way the system, the health system was set up. And families usually know a lot about the health system by this point. So really using their expertise to help you. And also, so how might things need to change for a local context? So that adaptation piece of implementation science. And then also really discussing with them, a lot of them aren't going to have implementation science training. So we need to sort of, and hopefully we'll have some help for that soon. I have ended up having about 10 hours, so I'm getting there. I'm still not a specialist, but I at least understand a lot of the key words. But talking to them about the barriers and facilitators or enablers, depending on what term you're using, is really important, because they're probably going to know, because they've either run into the barriers, or their clinicians run into the barriers, or, you know, they will probably have some pretty good ideas. And not forgetting to do those barriers and facilitators, not just with the clinicians, but potentially with the patient group as well. And then you're also bringing in your patient partners potentially to co-facilitate those groups, to go over make sure the questions we're asking are correct. So really thinking about all of those different groups and how to, again, make that straight line, keep going all the way down to the patients. And also using their expertise on who we should be talking to. They're probably going to have a lot more information on who they've written the letters to already to advocate when somebody said no, who they had to do this to, who they had to go through, what are the different steps in the process, and really using that to figure out what policymakers or clinicians or advocacy groups or funders that are outside of the government organization that might fund this work. So really talking to families about at each step of those, you know, at each step of your implementation science is really, I think, going to make your lives easier, because they might have that information just because they've had to deal with it. Yeah, so I think that's a lot of the different places. And then obviously knowledge translation, if you need something for patients, they're going to be involved in that. But that's sort of a bit of an overview of various places that they can, but happy to answer questions on anything about that. So I'll stop there. I see there's things in the chat, so I'll answer in the chat if there's if things I can answer, or we'll wait till after the next one.
Yeah, so really highlighting all those different ways to be involved, and this can be a little different, but really, thank you, Carrie. That was a great explanation on these aspects. And one thing I just want to add is don't get bogged down with the terminology. It's a mess with KM implementation, barriers, facilitators. It's really around knowing what you're trying to do. So what makes sense for the people that you're working with, and being able to kind of connect that back. So if it's strengths and challenges or other ways to be able to work with the people that you're working with, and make sure that makes sense in that way. So did anyone else have, well, obviously questions welcome from the audience, or anyone else on the panel that want to add to this piece?
I might just add one thing, and that's in thinking about KM, who's the best messenger for these key messages for action. And in some cases, it will be the family. They can be at the forefront. They can frame that message. They can deliver it. They can engage people in a way that a researcher may not be able to, or a health care provider may not. So think about that when you're enacting your plan. And there are, you can engage family partners, family members at every stage of the research process and the KM piece.
Yeah, and specifically, if you're already working with patients or you're not, some patients should look at your patient engagement section and your lay summary. Those are two sections of the protocol that probably should really be looked at by patients. If you don't have any, then bring it to citizen engagement and we can help you out with that. But I think that's really important to think about, that you have some eyes on it, to just look at that from that perspective.
So anyone in the audience, feel free to raise your hand if you want to either add your own comments or your own experience to this piece. And while you're thinking on that, I will just say there's a ton of resources that have been put in the chat. So don't worry about trying to copy and open all of them. We can, Pierre, I'm hoping you can help with this, collate that and send that by email afterwards as well, so that you've got that list. And we're also working on kind of updating and connecting some of those other resources that connect to all of this work. So think on your questions, and I've got one more for the panel before we open it up for full audience. But again, anytime. So the next one is around recognizing the importance of considering equity, diversity, inclusion, decolonization, and indigenization. So throughout your application with your own experiences, what have the ways that you have been, or some of the strategies that you've used for maintaining this focus throughout your protocol development? So there might be specific areas, your own experiences, some of the ways that you've been able to think about that in your own work. And we're hoping to be able to have a session that focuses a little bit more on this specifically, but still wanted to be able to get everyone's perspectives on this question.
I can get us started. Oh, Stephanie, go ahead.
You can go.
So I can get us started. I mean, I think this is the hardest one for many of us because I don't think it was a strong focus for many. There are some projects that it was, but not all the projects had a strong focus for this at the beginning, especially in the patient engagement side. So a lot of it's been about finding the right people around the table, and also just considering how to make the people that we bring to the table feel welcome and feel included, and not asking them to sort of be representative of anything, to just be themselves and their own person, and bringing what they wish to. So I think there's needs to be a lot of work that we need to do, as well as sort of a welcoming. And for me, it's all about learning. And I think even though a protocol is supposed to be sort of what you're going to do, I do feel like there's an element of learning in EDI/DI that we are all still on a journey on, or many of us are, and acknowledging that, I think, throughout is going to be important, because I know, for our project, we're not there yet. We're slowly working towards something, but we're certainly not there. And I think acknowledging that we're not there is an important aspect of trying to get somewhere.
I will echo Carrie's sentiments that it's a learning process, and we come with perspectives based on our own experience that benefit from diverse experiences to help understand how the world works and how people are impacted in a more thorough way. There's a tool called the Intersectionality and KT Toolkit that one of my projects has used in the past, and I'll put the link in the chat as well. And it's something that is designed for implementation research, so it helps you reflect on intersectionality, some of the EDI/DI considerations as you go. It does not address Indigenous aspects, so keep that in mind. but it might be useful for your team to look through and see if, we used it to help look at our research team to see, was it diverse, and how could we, what voices were missing, and it can also help in guiding other parts of the process. So I'll pop that in the chat.
And just in case there's people that aren't familiar with the term intersectionality, do you mind just explaining a little bit of what that that means? With like, people can look in the chat for the details on that, but just briefly.
Sure, and again, I am not the expert on this, but just looking at how different characteristics and experiences intersect to create meaning in a person's life. I probably totally butchering this, but
Yeah. The way people connect, and you're not just one. You don't mean one.
Like, you have a gender, you have an ethnicity, you have a socioeconomic status, you have a regional relationship, and these and other things affect the way that you experience the world.
And if I could just jump in and build on these excellent points that have been thus far. In my own experience, because I also don't see myself as an expert in this area, I have in the last several years attempted to include a research team member who has expertise in this area. So not just looking at the diversity of my team, but actually having someone who understands how to collect data, so develop data collection methods and data analysis methods that would reflect EDI as well. So, it's not just in the team, but it's also our research methods that have to have that lens, that can include that lens as well in our research methods. I just wanted to throw that in there.
And if we think about KM, who are you trying to reach? What methods are you using? Are those methods going to reach a diverse population? Are the messages going to resonate with their experience? Say you're trying to, it's important to reach newcomers to Canada. What are some pathways to reaching those people, and what are the best ways to impart the information or engage them? So consulting with people with experience in those areas can help to make your strategy more effective and more inclusive.
Thanks, everyone. Alan, was there anything you wanted to add about the protocol and what's on the screen?
Maybe the one thing that I can add is I think we understand that this, writing a plan for EDI/DI is complex and can be overwhelming. There are some prompts that you can use to address your EDI/DI plan in this section, the EDI/DI section on page 20. Some of your plans can also be represented in other components of the template in terms of which populations would be involved in your protocol, for example. It could also be represented in your patient engagement section of the protocol. So all answers are acceptable for this, and you can sort of work your EDI/DI components into various areas of the template. Don't feel restricted to have it all on this page 20. So there's flexibility there, and there's also overlap.
And then I believe there will be more supports and education and training related to this topic over the course of the network. So you will have opportunities to reach out and ask for support and to learn more about things that, for me, I might not know, I don't know them yet. So important to connect and see what's happening out there.
Great. So now I'm going to leave it for a little bit of awkward silence while people think of their own questions. So hopefully we can bring some, or if you have your own experience in working on this protocol that you want to share, not a question, then really interested to hearing your thoughts on this as well. hopefully some ideas are percolating.
I have a question. Sorry, I can't figure out how to put my hand up.
Great, go ahead.
This has been really helpful. Thank you so much. I'm Gail Andrews. I'm the research manager for the pain study out in Vancouver. We, with Dr. Hal Seiden and Dr. Tim Oberlander, we've been working on studying a pathway to treat pain in kids with really complex healthcare issues. And it looks like, we're almost done. It looks like it worked. So I think what you said, it was very helpful. I know there's another seminar coming, and so I won't assume that this is the answer, but what I think I understand is that the one question about the effectiveness of the intervention is the question that we're going to try and answer in terms of implementing it. And then the second question is what factors contributed to the success of that intervention. And that second question would be the implementation science question. And I loved our parent liaison who said the third question is, will it work for parents? So do I kind of have that right?
So Gail, I'll jump in and say, I don't know your project in detail, but based on the 3 or 4 lines that you suggested, it sounds like you're moving in the right direction for sure. And I don't think it was mentioned. If it was, I didn't hear it, but each of the teams will be assigned in addition to a KM coach as Stephanie has indicated. You'll also be assigned, if appropriate, an IS expert who will coach you through the development of your protocol. So there will be some back and forth on that, but you'll definitely get some, one-on-one coaching free through the network from an implementation science expert. But it sounds like you're moving in the right direction.
Yeah. And I would say, Gail, chances are your third question about parents is going to be included in your second question, the implementation science question. So it won't necessarily be a separate question, but it's something that you're going to be looking at in terms of a barrier facilitator, or that in that second question, it's sort of encompassed in that, because patients are your end users, even if they're not what your implementation science is directed at. Does that make sense? Okay.
Yeah, and it's really about that how question for your implementation. How does this work? How does it get implemented? What are those pieces that are at play within it to be able to make that continue? What's happening in the context that might be impacting what's able to get or what's able to be implemented? And if something changes, does that change the implementation aspect? So there's lots of different areas to be able to think about within those implementation questions, and narrowing what is the most relevant for you to be thinking about in that stage as part of it, and trying to keep track of some of those elements as well, so you can understand why it's working, why that implementation happened, or if you find that it's not, why not? So that's a big piece of what some of the implementation aspects can be looking at as well. But great question. Did you have any follow-up?
Oh no, I was just gonna say, I'm so glad you guys are the experts.
Any other questions?
I might just address something, just for a bit of context. I see that there are some people on the call who have been part of the first 4 teams who are developing their implementation science protocols. I also see some teams who indicated that they would be part of our second wave of project development, which will start, I believe, in January. So for those who are part of the second wave, how do you feel about that timeline? Do you feel like you're sort of, so for example, Gail, I think you would be part of that timeline. Jen, I think I see some others. Pat, do you feel like January is a reasonable timeline to start developing your implementation science project?
Depends on, Pat here, it depends on what we decide on exactly our implementation science project to be. Could it include, for example, obtaining funding for the implementation? Because that's obviously going to be much more, so influencing governments to participate, or health authorities to participate in these things. Is that part of? It seems to me that's pretty important implementation science question. How do you do that? And we have had a fair amount of experience in that with our partner, who is a not-for-profit. And that, we've had very good uptake from families. We've had very good, heavy involvement of families in all of our development. So they've been really strongly integrated in that. We probably could do better with EDI, like everybody can in the world. And but the biggest barrier for us is always, okay, we know something works, we know how to do it, we have to have it funded. And so that's an implementation science question, I would think. And is that suitable for this program?
I mean, I'll let the ISS experts jump in, but I think so. I mean, I know that's one of the things that we're looking at in our project is sort of how to fund it. And health economics is sometimes useful in that. I don't know if that applies to your project. Janet or Stephanie, you want to jump in?
Yeah, so I'll make a first run at it. You pose a really interesting and important question, I think, Pat, in terms of, the effectiveness has been established. And so if your focus is on wide scale spread and sustainability, I think questions about how to support sustainability, an intervention that has known effectiveness and proven effectiveness, understanding how to engage funders or decision-making partners. I think those can be framed as an implementation science question as well.
Anything else to add on that one? Looks like there's another question.
Hi, this is Jennifer Crosby. Yeah, so Alan, to your, I'm the PI on Megateam 2.5, and to your question, Alan, I'll say I'm still thinking about it. I really appreciated Pat's kind of comment and probing around there. We're driving to our analyses in January for the first phase, and so this has been a really helpful session. I'm looking forward to the next two. So I don't know 100% if we're like fully ready to for say January, but we're definitely sort of moving around there and thinking about it and working towards it. A big part of what we'll be doing in January is looking at those initial results, but with an eye then to for sure thinking about what those are and what the implementation looks like. So yes, I would say we're in the contemplative stage, the planning phase, the development phase. I'm not sure if we'll be ready right at January, but I'm hoping to have a better defined plan for sure, based on these sessions over the next month or so to start to winnow it down and to define things a bit better.
And Jennifer, I'll jump in to say, like, I don't know if any of us are ever prepared to fill out these things. Because, I mean, I don't know, but implementation science is new for most of us, I think. So certainly, and also, like, I was looking at the KM chart and I'm like, we have to be careful also that we don't assume what the barriers are and assume what those strategies are before we actually do the groups or the looking at the data, like talking to the people. So it's like, everything in there, I think, is much more malleable than in a normal sort of CIHR grant, which we're used to. It's like, we have the process, we have this, we have that. But this, I feel like, because we're sort of going, we don't know what the barriers are. We think like funding, we think funding is going to be one of them. We think that this is going to be one of them. We think that is going to be one of them, but we don't know until we talk to the people. So I feel like it has to be based on the things that we're trying to do, that it will be still a lot of questions even after you've finished it.
Just conscious of time, so wanted to ask each panel member just if you have any final thoughts to leave people with as they start thinking about this quite a bit more by the sounds of it for several of these projects.
I'll just say that the process of developing the protocol, using the template to guide you, is really a reflective exercise. So I think you, even if now we're asking the question, do you think you'd be ready in January to start writing your protocol? Once you get into it and start moving through the various sections, I think it is a reflective exercise that will help you sort of narrow in on what a relevant implementation science question might be for your project.
Any other?
My thought was, I'm a bit of a theory wonk, but I would say that if you can frame your work in theory frameworks from implementation science to knowledge mobilization, I think that you'll have a leg up because people have done work to figure out what works and how things are linked and what the process of implementation looks like. So look for that as guidance.
And I'll just add on to that saying, I think all of those are really important and can give you some of those step-by-step processes, but make sure when you're talking to patients, you keep it really simple. Create a common language, whether that's barriers, facilitators, and strategies, and that's all you're talking about, or are you bringing the framework and how do you simplify that? But really thinking about how do you make this possible for patients to be involved without having to necessarily understand all the theories and processes, unless they want to, because some of them may want to, some of them may be right in there with you, wading through the weeds, but a lot of them won't. So, and that's okay. We don't need them for that. We need them for something else. So just making sure you're asking simple questions.
And any quick comments, Ellen? And Pierre, if we can get the last poll ready to go, we're just seeing if anybody learned anything in the last piece. But go ahead, Ellen.
I mean, no real quick comments, but I do hear your conundrum, Jennifer. Like, if data aren't analyzed, how can you consider, the next stages of the project? So we can talk about that as well. It can obviously make for problematic future planning if you haven't analyzed, data from phase 1 yet. So we totally understand that.
Great, so we are right on the hour. So if everyone can fill in this last poll just to be able to see if we're trying to meet the mark with some of these sessions, whether we'll have the next one coming up. So Pierre will put that link in the chat if you haven't registered. These have been really great sessions that we've seen, and we were able to design what this looks like. But the Center for Implementation has been running these kinds of training, and we get to target that for this session. So watch for more details coming out about that one, and hopefully you can all register and feel free to engage with, we'll send around the resources and keep your questions coming that we can work through them as the Child Right Network. All right, and you can see 94% feel more informed after this session, so that's great. But we've still got some work to do around involvement with that piece. So hopefully we can provide whatever support you need to be able to make that project work. And I think we can end there.
All right, and so thank you all, everyone for joining today and sticking through to the end. Yeah, we'll be sure to send out an email in the next day or so following up with the session today, as well as share some of those resources and contacts that were conveyed in the chat. So yeah, stay tuned, and yeah, of course, if you have additional questions, feel free to connect, and we look forward to connecting to you soon. Take care. Bye.